I'm Emily Haozous. I'm enrolled Fort Sill Apache. I'm a nurse, and I work as a research scientist with the Pacific Institute for Research and Evaluation. I'm based out of the Southwest Center, and I live in Santa Fe. And it's really important to me that we pause for a moment and recognize that in this conversation, we are talking about people, we're talking about loss, and we're talking about a subject that is devastating to people in our communities. It's so easy to distance ourselves by talking about this at a distance. But at the end of the day, this is a discussion that centers on loss and the continuing effects of colonization and intergenerational trauma and historical trauma. So, I'm here to talk about epidemiology, so I'm going to go into that. But the nurse in me couldn't let this pass by without mention. As Dr. Bigfoot described, it's really important that we have time for silence and pause and reflection. Okay, next slide. So I have no conflicts of interest to disclose. And so next slide. So a little background. What's a nurse doing talking about epidemiology? So in 2017, an NCI intramural team was using some national data sets to look at death certificate data for cause of death, and they were comparing it with cause of death in other countries to, just kind of look at what was happening in the country. And every analysis that they ran, they noticed that Native Americans were dying at disproportionate rates. This was really disturbing to them, as you would imagine, and they wanted to make sure that what they were doing wasn't a data problem or an issue with what their analysis. So they knew me because I'd worked with another intramural team a few years earlier, and they knew that I had a certain amount of expertise with Native American data and Native issues. So they called on me to help them sort this out. I tried to refer them to somebody else, but they kept calling me. So they brought me into this research group, and I talked to them a lot about how to refine their analysis of AI/AN data so that there was less of a risk of racial misclassification. So they were able to hone it down there, but they still had this disproportionate problem. And then I talked to them about contributing contextual information that allowed the scientists who were doing the writing to reframe their narratives. So we had a lot of conversations regarding how to write about Native peoples and other people of colors in a way that directed attention to the structural conditions that create disparities, instead of following the old patterns that focus solely on people instead of structures. And I really wanted to emphasize for them that we need to write, when we write about problems in communities or disparities, that we write about the historical and structural conditions that are essential that create these problems. Next slide, please. So this became a collaborative and ongoing relationship. We've published 6 articles to date, looking at premature mortality through several perspectives, including focusing on specific causes of death, like alcohol-related death, projecting youth mortality trends. In 2021, we were one of the first groups to look back at non-COVID excess deaths during the first year of the pandemic, and that helped to shine a light on the real health equity problems that were being made more evident during the pandemic. We, in that project, helped to provide the evidence that not only were people of color dying more from COVID-related causes, but we were dying more often from other causes of death as well. So next slide. So again, I want to acknowledge first that this is not easy work, and the data don't give us the full picture of what's actually happening. So when I say this, I'm saying a couple things. First, the data aren't complete. Racial misclassification is a known issue for a lot of reasons. So what does that mean? When a person dies, their race is noted on their death certificate. So if the person, for some reason, doesn't code as Native American, like when they died, they didn't have enough beads and feathers on their body, the person who's filling out the death certificate will most likely first list them as something else. And for this reason, of all races, American Indians and Alaska Natives are least likely to be identified accurately on death certificates. And I know a lot of the people who are attending this may already know all this stuff, but I want to make sure that everybody who ends up seeing this presentation really understands why racial misclassification is a problem. Because of work of some excellent epidemiologists who came before me, And I'm not even an epidemiologist, so what do I know? But we do have a gold standard for improving the quality of the data we can use by creating these data linkages that cross-link the vital statistics data that come from counties that have a known higher concentration of American Indians and Alaska Natives with very specific databases that have confirmed American Indians and Alaska Natives, like the counties that are, so the known counties are these purchase referred care delivery counties. I'm looking at two different screens. And then we link them with IHS, and we link them also with tribal data. And so with these linkages, we can build a much better sense of where we have health equity concerns. We can also start to document where we have growing successes, so we know what is actually working across Indian country. So I can show you more about what I mean with pictures. So let's look at a couple maps. So next slide. So this is a map of population density based on the 2020 census. This is the population of the whole country. And the places that are darker blue are more population dense. Knowing what we know about the general US population, just by looking at this map, you can see that the places where we think of American Indians and Alaska Natives having reservations, or places where we tend to live, do not have the most people. There are big concentrations of populations around major cities, not necessarily Native Americans, although we know urban Indians follow those trends as well. But anyway, we have a lot of people on the coasts, on both coasts, and there are more people on the eastern side of the country with huge areas in the center of the US that have fewer than 50 people per square mile by county. Next slide. In contrast, when you look at a map of the US that shows population density focused on American Indians and Alaska Natives, you get a very different picture. So the concentration of natives is predictably higher west of the Mississippi, thank you, policies. And save for there's a few pockets of natives here and there in Maine and upstate New York and North Carolina and so forth. So we know that the accuracy of death certificate data is much higher in regions where there are more American Indians and Alaska Natives. So look at this map for a minute and kind of memorize in your head where the darker green areas are. You can see them in Arizona and Montana and North and South Dakota. So kind of image that. So next slide. This is a map of the purchase referred care delivery areas by county, the PRCDA. We used to call these CHISDA, now so much more complicated. You can see a near perfect overlap between what I was saying to memorize, those darker green areas on the last map. Now they're dark blue. Now, those are the PRCDA counties. When we draw data solely from those counties, we know that the data quality will be better. We know that people will be more likely to be named American Indian or Alaska Native from those counties. Then when we link those data with IHS data or with tribal data, we get even more enhanced data. So we know we have a much better picture of what's happening with American Indians and Alaska Natives. So reports using data linkages and reports that use data that are only drawn from PRCDA regions will be much more accurate. Okay, next slide. So this is not easy work. And I just talked about race and misclassification, and that this is a known problem. So data also tells a story, and how we describe our results frames how we think. So if we frame everything negatively, that becomes the story. For example, if we talk in our papers about how non-Hispanic white people die of accidental drug poisonings, and we talk about people of color dying of drug overdoses, that's a very different framing. That becomes the story, is that some people are overdosing, some people are accidentally poisoning themselves. Data have power. Because of this, data can be used to shape public policy, public opinion, and it drives funding. And when we talk about very painful topics like suicide, we have to frame the data within the larger context of what's happening in the world to drive these rates. And we have to be very careful to observe over and over that suicide does not define us. We want to be sure to reinforce for ourselves that we are defined by our culture and our communities and our steadfast resistance to all of those forces that have tried to eliminate us. Okay, next slide. So with that said, I want to show what we do know about suicide in our communities compared to other populations as seen in national data sets. So what we've done looking at, oh, hang on a second, I'm going to do this. Thank you. Looking at national data sets, we look at deaths of despair. These are drug poisonings like overdoses, suicide, and deaths from alcohol-related causes. And we can see that American Indians and Alaska Natives have much higher rates than all other populations, which almost doubles non-Hispanic whites, which are the second highest group. All three of these causes of death don't happen in isolation. So when we see this, the first thing that comes to mind for me is the limitations in accessibility for behavioral health services for American Indians and Alaska Natives through the Indian Health Service because of chronic underfunding. This isn't a problem with the IHS. This is a problem with how much money the IHS is given. Note that this is data from 2013 to 2017, and access to care because of the American Affordable Care Act. Access to care from the Affordable Care Act has helped to change this story slightly, but it's a very big ship, and big ships are very hard to turn. Next slide. I like maps, so I'll go back to another overview map. And for this map, I want you to look at the one that's on the upper right. And this is just the continental US, because apparently Alaska and Hawaii don't matter. But if you did an overlay of the population density for American Indians and Alaska Natives, in this map, you'll see overlapping counties. So here we see that the suicide rates are hotspots in Oklahoma and New Mexico and Arizona and the upper Midwest and Montana, North and South Dakota. So we have hotspots in areas that have more American Indians than in other regions. Next slide. Now, this is a paper that we published in 2017, and the next couple of slides are from that. We have graphs that show absolute change in all cause and cause-specific age-standardized mortality. The first one, this first slide is with men broken down by age group. And I highlighted the suicide groups in red. The bottom scale got cut off, but it should say absolute change in mortality per 100,000. And so what this is doing is it's comparing the suicide rates from 1999 to 2002 against 2011 to 2014. And so in men, it increases over time, but then when you get to men age 50 to 64, it only increases just a little bit. Next slide. We have the rates for women. In contrast to men, women's all-cause mortality decreased overall. The previous slide that had men's all-cause mortality just super huge. But I want to focus more on this. I think I can run over just a little bit. Is that correct? I'm just going to assume that somebody's like raising their hand because I can't see you because I'm going to run over, but not a lot. The women's all-cause mortality did increase just a little bit. But we see on this positively that there's good progress being made in addressing cancer, heart disease, and cerebrovascular disease deaths. But suicide rates do increase over time in all great age groups. Okay, next slide. For comparison, here are graphs for non-Hispanic white men and women. And there is an increase in mortality for younger men, but everybody else sees an improvement in all-cause mortality. So their rates go down. Suicide rates did not increase as much for white men compared to Alaska Native men until you get to this older group. And remember, I pointed out that for American Indian and Alaska Native men, it just goes up a little bit. If you look at this rate, it more than triples for non-Hispanic white men when they get to age 50 to 64 years. That is huge. Suicide rates for white women increased at slightly higher rates than those of American Indian women and Alaska Native women across all ages. So I put this here to show that while our rates American Indian and Alaska Native rates are awful, they're stinking awful, they aren't always the worst. That huge jump in white men age 50 to 64, that is alarming and it's not easily explained. So next slide. And this slide is kind of silly, but because I ran out of time. The summary here is super complex, and I want to try and put it together in just a few points. The story is only as good as our data. We have done really well to try and narrow our data sets to reflect what is actually happening for our people. The next step is to make sure that our tribal communities are part of the conversation in a substantive way, so that the data reporting is aligned with community values without violating tribal protocols. Second, I gave you some very big picture maps and graphs to show that, yeah, we know that rates are high in Indian country. But I gave a comparison graph just now because I want to make sure that we are aware that this problem is a problem that plagues a lot of communities. We don't want to cherry pick our data and unintentionally fall into stereotyping our communities as one thing or another so that it defines us. And third, I want to be sure that we tell the stories that go along with this data. When we look at those maps, what else do we see? These are remote and rural areas, often with very limited access to resources, especially specialty healthcare, behavioral health, inpatient substance use treatment facilities. Inpatient behavioral health facilities are incredibly hard to come by for minors in these regions, which makes this all the much worse. The general population density map does not represent Indian country, and our health outcomes tell the story. And finally, I didn't even crack the surface on American Indians and Alaska Natives living in urban areas, which is another issue that needs so much more attention. But obviously, I didn't have time. So thank you so much for this, and I look forward to our conversation.